Northwest Women's Care Division of Education, in conjunction with Ross University School of Medicine, presents a discussion on spontaneous abortion.
We're going to be presenting on spontaneous abortion. To begin the discussion, we'll present a case presentation. This is a common presentation that you may see in the office setting. A 40-year-old woman, G3P1, one abortion at 9 weeks gestation, comes to the office complaining of vaginal bleeding. A urine pregnancy test was positive 3 weeks ago. She initially experienced breast tenderness, however, it has now disappeared. She denies passage of any tissue vaginally. Now, with any pregnant woman, especially early in gestation, that presents with vaginal bleeding, spontaneous abortion should be a differential. And to define spontaneous abortion, it refers to a pregnancy that ends spontaneously before the fetus has reached a viable gestational age, and this is usually considered between 20 and 22 weeks of gestation. The World Health Organization defines it as expulsion or extraction of a fetus, of an embryo or fetus weighing 500 grams or less from the mother.
Spontaneous abortion is actually a very common complication of pregnancy. In fact, it's the most common complication of pregnancy. Anywhere from 8 to 20% of all pregnancies under 20 weeks of gestation end up being spontaneously aborted. Most of those under 20 weeks are actually within the first 12 weeks. So the thing is, most spontaneous abortions are not clinically observable, and that's because they're termed biochemical pregnancies, in which you will find beta-HCG in the maternal blood, and in that situation, the woman will actually undergo ovulation and will actually menstruate normally, and so that actually has to be clinically classified as another type of abortion. So 1/3 of products of conception from spontaneous abortions occurring at or before 8 weeks is known as blighted or anaembryonic ovum. And then the 2/3 of pregnancies, or 2/3 of cases in which you have spontaneous abortion, it's actually due to some sort of dysmorphic or stunted or macerated embryo. Etiology, I've broken this down by trimester. So the first trimester, 2/3 of your abortions are due to chromosomal abnormalities. In fact, 95% of chromosomal abnormalities end up being abortion. So now chromosomal abnormalities can be either parental or they can be random. Parental would actually mean that you're passing the tendency to abort down your line. And then there's random mutations, which actually is recurrent, or it's actually your main form of abortion. And then the second reason for abortion could be to progesterone deficiency. Some women have a decrease in progesterone during the luteal phase, and to treat that, they've started prescribing progesterone agonists or supplements to such women, but studies have not shown any sort of improvement in spontaneous abortion. During the second trimester, most of your factors are going to be host factors, such as uterine abnormalities, fibroids, cervical anomalies. And then there's also acute maternal infections, such as listeria, chlamydia, etc. You can also have maternal endocrinopathies, such as thyroid dysfunction, SLE, Cushing syndrome. One thing I forgot to mention during the first trimester also is congenital anomalies, which can also be due to exposure to teratogens. If you know anything about embryogenesis, the first 3 to 8 weeks are very crucial for organogenesis, and that's when organs are formed. So this is the time when the fetus is actually very vulnerable to teratogens. So now, risk factors. Age is your biggest risk factor. If this means anything, the age of 20 and the age of 45, there's an almost 70% increase in the risk of abortion. So it's 9% at the age of 20, and then it's 70% at the age of 45. Now the next thing you have to worry about is previous spontaneous abortion. So if you have a history of aborting, you should consider the possibility that of recurrent abortions. So if you abort once, the chances of you aborting again is 20%. 2 abortions, it's 28%, and then followed by that, if you have 3 or more, it's 43%. Smoking can cause abortions basically because of its vasoconstrictive effects and because of its anti-metabolic effects. Alcohol, cocaine, non-steroidal anti-inflammatory drugs such as naproxen, ibuprofen, etc. They can cause abortions because of their prostaglandin inhibitory effect, which basically causes it decreases the implantation, the ability of the fetus to implant. Caffeine and maternal weight are also other factors.
All right, so I'm going to be talking about the different types of spontaneous abortion, and as you can see, there's pretty much a list. There's threatened, inevitable, incomplete, complete, missed, recurrent, and septic. But for my talk, I'm going to be talking about the first 5 different types of abortions, and kind of as an aside for later, I'm Jamie, and Salman's going to be talking about recurrent and septic. All right, so the differential diagnosis, basically, when you have vaginal bleeding, there can be kind of like a physiologic vaginal bleeding that can occur in about 20 to 40% of women in the first trimester, and this is what we consider to be physiologic. We also kind of worry about ectopic pregnancy, cervical, vaginal, or uterine pathology, urinary tract infections that can also be kind of mistaken for vaginal bleeding, placenta previa, congenital bleeding disorders. These are all kinds of differential diagnoses that we consider when a woman comes in with vaginal bleeding. And as far as the diagnostic evaluation goes, the clinical assessment of a woman with vaginal bleeding and a closed cervix is pretty much insufficient for predicting the prognosis of basically like the spontaneous abortion, just due to the fact that, again, about 20 to 40% of women have normal vaginal bleeding in the first trimester of pregnancy. But so clinical assessment aside, the best kind of diagnostic tool for like determining whether or not a pregnancy will basically last is ultrasonography. And again, like I said before, it is the most useful test in the diagnostic evaluation for a suspected spontaneous abortion. And some of the definite diagnosis of a non-viable intrauterine pregnancy basically consists of number 1, absence of an embryonic sac, number 2, absence of embryonic fetal activity, and number 3, you have the absence of an embryonic pole. And some of the reassuring ultrasound findings, obviously, if you can actually find the fetus and it has proper fetal cardiac activity, these are some of the reassuring signs that the pregnancy will actually last. And some of the findings that are predictive of pregnancy loss would be things like abnormal yolk sac, slow fetal heart rate or absent fetal heart rate, small sac, and subchorionic hematoma.